I am a pelvic health physical therapist, so I see 100% of the time pelvic health patients for really any diagnosis pelvic health related. So urinary incontinence, bowel issues, pelvic pain, related to neurological conditions, oncology conditions, if that person's had radiation. I see a lot of transgender patients who mostly male to female, so like a vaginoplasty patients. And yeah, kind of any of the above. I've done pelvic health for 12 years, and I work in an outpatient hospital-based setting at Johns Hopkins, and also run their pelvic health residency program. So a post-professional training program for therapists wanting to specialize in pelvic health. So as I mentioned, any pelvic floor dysfunction, I treat a ton of pelvic pain, which is really where the WINBACK comes in most handy for me. But pain, weakness, urinary leakage, bowel incontinence, constipation, you name it, anything going on in the like abdomen or pelvis, I'll treat. Depending on what it is, obviously if someone has more of a weakness issue, you're going to be strengthening and uptraining the system and working on motor control. But for more pain diagnoses, particularly that I work with, such as like endometriosis, interstitial cystitis, even some like colonic dysmotility disorders. So the colon doesn't have the innervation it needs, and so it just doesn't move enough. And you're working more with maybe connective tissue issues. I usually do a combination of manual therapy, so really trying to get that tissue to just move and have more mobility, so our organs and our muscles are more functional. But I always pair that with kind of functional exercises, and I definitely use modalities, whether that's stim, heat, ice, to kind of help augment the manual treatments that I might be doing. I was first introduced to WINBACK probably 2 years ago. The director of our department had, I guess, an informational session by one of the WINBACK reps, and he trained a handful of our staff in our clinic who thought it might be beneficial for certain populations that we treat. So I was one of those therapists, and I was cautiously optimistic, I would say at first. I'm a pretty big believer in you don't know something until you try it. And so I've done this for long enough to know kind of like what I normally do and like what works and what doesn't. And it's easy for me to then bring in something, especially with a patient that I've been working with for a while, to then, see if it made a difference or not. And also when it's a reliable patient, to say, hey, after that session, did you notice a difference with this? Did you feel better? So I'll kind of experiment with it where patients with similar diagnoses or similar type findings, one of them I'll add it with and one I won't, to kind of do my own little experiment on hypothesis. And I have found I've become a believer. I think it really just helps like augment and give more like staying power to the manual treatments that I do, especially for those pain diagnoses. So especially like endometriosis patients who just have a ton of like abdominal tension and guarding because they've kind of chronically been in pain. I think it helps let them just kind of let that go. I use it a ton for scar tissue in the abdomen. So I treat a ton of women who have had even just laparoscopic procedures, but cesarean scar tissue, abdominal procedures. And it really helps like if you do it beforehand and or after. I think it kind of helps give you that more tissue mobility and more staying power, and patients really notice it. And even for, I was mentioning earlier, kind of the bowel dysfunction. So I work a fair amount with people who have like neurological conditions that affect the motility of the gut. So their colon, they might have like gastroparesis where the colon actually like does not contract enough. They'll respond well to manual therapy, but I kind of sandwich it with the WINBACK. So I'll do a little WINBACK before along the course of the colon and then also after. And I think it helps improve the blood flow. It helps me actually mechanically get in a little bit better as well. And I also think then patients just tolerate it better. So those are the big things I use it for. I also use it a lot, I will say, for kind of the deeper hip rotators that I want to get in. So if someone has coccydynia or more like deeper pelvic and rectal pain, I don't insert the probe by any means, but if they are prone and on their stomach, I will use like a smaller little transducer head and do it kind of like right next to the tailbone. And again, I find it gets pretty darn deep compared to a superficial heating pad. And you know, how I know it's effective is patients are like, you know, they want to take it home with them. They love it. They're like, can we do that again when they come back? Because they got a lot of relief, and that relief lasted several days. The only thing that like from patients that so one thing, it heats up quickly, which is nice, right? And patients can, I think what I've learned over the years with different modalities that I've tried, even if it's a placebo effect, which I don't think it is in this case, patients like to feel something, right? Like they want to feel that something is being done to them. Like we have a few lasers and things like that that they don't really feel. But this they can feel immediately, which they like. With that said, like everyone has very different thresholds of their sensation. And so it heats up pretty quickly. So you just have to be very gradual and kind of play around with the settings a little bit. But yeah, patients give wonderful feedback. I think I use it at least once a day. Okay. I mean, usually if I have a full, so my schedule now is like probably 75% patient care, 25% other, like administrative things. So some days I don't see like a full caseload, but I mean, yeah, I mean, just thinking about my afternoon today, I know 2 patients I will use it with. Yesterday, I used it once. Some days I'll use it 3 times. I mean, I would say on a minimum, I'd say 5 times a week. On the high end, 10 times a week. Yes. And, you know, so the resident, so our pelvic health resident who's about to finish, they've been with me for a year, and we've retained them. So they're going to be working downtown at the main hospital. And one of their big asks was like, am I going to have access to a WINBACK? Because it's like really integral now to how they practice. And it's probably because they've worked under me and I've, you know, encouraged it. But I think they've seen the benefit too and how patients really respond well to it. One in particular, she has that gastroparesis, like I was saying. So she's a really interesting case. She had a brain tumor. So she's very young. She's like 42. And when she was 36, she was pregnant, was having a lot of like GI issues during pregnancy, which is like not that uncommon. After she had the baby, she was having all this balance issues. The GI stuff was still going on. Turns out she had a huge tumor on her brainstem. So they removed the tumor. She had to basically relearn how to like use her whole like left side of the body, etc. And her colon has just never worked the same, right? So she's had the $1 million workup of every GI study possible. And so there's a test where you basically eat like radio opaque food, and they look at the transit of your food through your colon, and she has like severe gastroparesis. And so they basically recommended that she get a colectomy and have an ostomy bag. And she was just like, no, I'm not going to do that. She's also too vain for it. And she would tell you that. So she kind of has sought out all these other therapies and medications. She's definitely on a lot of colonic stimulant medications, like Amitiza, Trulance, you name it. Like, she's on a ton of medications that none of which have really been that effective. So she ended up coming to see me. People kept saying that she had pelvic floor dysfunction as well, which basically means your pelvic floor is contracting when it should be relaxing when you're trying to empty. She does not. It's like totally normal. She's had manometry. It's totally normal. She can expel the balloon. So it's all from above, right? It's all in her abdomen and her colon. So really, I see her once a week at least, sometimes twice a week, to really just like mechanically move things along her colon in conjunction with the WINBACK. And it's the only thing that keeps her going regularly. So she, I mean, it's like a joke when we come in, because there's usually like, there's a couple of us who, you know, really use the WINBACK frequently. So like, if I don't have it and someone can't find it, you know, I'm like, go ask X, Y, and Z, right? It's like between two of us, basically, 2 or 3 of us who use it regularly. So she's always like, go get it. Do you have it in your room? Because there have been times when, like, you know, I go to get it, I'm like, someone's using it. So she in particular, I think it's made a world of difference for her in particular. And then I really, as I mentioned earlier, I treat a lot of women who have endometriosis. And while I am certainly not treating their underlying organ-based pathology with endometriosis, these women have had years of chronic holding. They tense, they flex their abdomen and their hip flexors, and it's really hard for them to let that go. And all that muscular tension around your uterus isn't helping their symptoms, right? Or their ability to exercise and do things. So I really have found the WINBACK is a huge, it just kind of like lets them relax, and I think it like repatterns their brain to tell that muscle like, oh, this is what it's like to not be tense right now. And I think because the WINBACK gets so deep, right, especially in the psoas and the iliacus, so I'll do it kind of in the lower abdomen, and they really just get a ton of relief from it and love it. So I feel like for those patients in particular, I it's like my go-to, right? Just like play around with it. Like, as I mentioned earlier, I would use it if you're really like not sure if it's effective, you know, don't use it with a new patient. Use it with an established patient who is used to your normal treatments, and then you add it on to see if it made a difference or not, right? I mean, that's what gave me buy-in. And I would also play around with, like, find a colleague, try it on them, have them try it on you so you actually know what it feels like. But I think, I mean, I would just explore with it. Like, like I said, I'm a pretty open-minded, I've done this a long time, and I like to try new things to see what's going to make me better. Like, I'm not perfect. And so I like having a new tool in my toolbox and one that's effective. But just be open-minded.